Welcome, everyone. Thank you for joining this session, which, as you know, is the final for the Most Innovative Development Project Award 2021 under the category of universal health coverage and COVID-19. My name is Francesco Obino. I'm head of programs at GDN, the Global Development Network. I'm very glad to be chairing this session today. Just a few words of introduction about the competition as we wait for a couple of people to still join and fix some technical issues. The Most Innovative Development Project Award is part of the Global Development Awards. This is a competition that has been running since 2000, and of course has been run by GDN since then, with very generous support from the Ministry of Finance, the government of Japan, and thanks to the administration of the PHLD Trust Fund at the World Bank. Along the years, we distributed over $4 million US in research projects and grants. Something very unique about the competition, beyond the fact that the longest standing program of the Global Development Network is the fact that it has two different components. One component which sits within right within the scope of all our other programs, which is a research component, the Outstanding Research and Development Awards, and there'll be a panel of finals for that category on Monday. I invite you to join that too. And an implementation component, that is an award for an NGO that is carrying out an extremely innovative project that deserves to be piloted and scaled up. So this is this competition is a way to identify innovative ideas and capacity in the implementation, and give it a chance to gain visibility and be scaled up thanks to some seed funding. There are 3 finalists today that are competing for 3 awards. The first 2 finalists will get $20,000 each, and will then compete in 12 months' time. So after an assessment of the implementation the first year, for a significantly larger grant of $200,000 under the auspices of the Japanese Social Development Fund. And that is the scale-up component of this program. Now, the way this session will run is that it's really a final session. So we have had a number of applications come in that went through a multi-step selection process, and we now have 3 finalists that will present their projects in front, of course, of a virtual audience in this case, but also, most importantly, in front of a jury. Now, the jury will, the jury. I'm hesitating whether to present the jury because we have still 2 jurors who haven't been able to join yet. But the whole evaluation process, is really composed of course, eligibility screening that we do in-house, desk review, but also business review. So we look into the capacity of the NGOs to run the programs they're pitching. There's of course due diligence in terms of administrative and legal processes, and of course a screening of safeguards in terms of the World Bank, the World Bank's own social environmental safeguards. I'll just introduce the jury for this award category today. We have 3 experts on the topic, which is universal health coverage and COVID. The first one is Dr. Abhijit Nadkarni, who is an associate professor at the Department of Population Health in the Faculty of Epidemiology and Population Health at the London School of Hygiene and Tropical Medicine in the UK, which is of course a well-known world-class research centre of these issues. Then we have Prashant Yadav, who's a globally recognized scholar in the area of healthcare supply chains. He's an affiliate professor of technology and operations management INSEAD in France, and he's also a senior fellow at the Center for Global Development and a lecturer at the Harvard Medical School. And we have Dr. Saeda Makimoto, who's principal research fellow at JICA with a research interest in international health, global health, human security, governance, Southeast Asia, in Southeast Asia and South Asia as a region. I propose that I hope the jurors will both Prashant and Makimoto-san will be able to join us very soon. I propose that, just in case they don't, hopefully they do. But just to mention that all jurors have already received the projects of the finalist projects, and the assessment of the project, of course, happens both offline prior to the session and online, thanks to the presentation. And right after this session, we'll have a joint meeting where we'll discuss how many awards to assign and what awards to assign to whom. Without further ado, I propose that we start the presentations. And I would like to invite the first finalist for today, Sarah Guidas, who's a partner coordinator and partnership coordinator representing the project. Partnership coordinators at Kid Home Development Network Foundation, which is the NGO we just put forward the project, and we'll present the project titled Access to Healthcare for Migrant Families in Thai Construction Site Camps. Sarah, I'd like to invite you to switch on your screen, unmute yourself, and present and pull up your presentation. We have 15 minutes to present, and then we'll have 15 minutes of questions and answers from the jury and from the audience. Good luck to everyone. And good luck.
Can everybody hear me and see my screen? Okay.
Yes.
Okay. Hi, everybody. I hope you're having a great day. My name is Sarah Guidas. I am a representative of Bandek Foundation, a Thai foundation which is formerly known as the Kids Home Development Network Foundation. Today, I'll be discussing our project submitted for the Most Innovative Development Project Award, Access to Healthcare for Migrant Families in Thai Construction Site Camps. To start, I'd like to give a brief overview of the contents of our presentation. First, I'll introduce the overall situation of the beneficiaries that Bandek supports, including their challenges with regards to health access. Then I'll introduce our organization, the project, before then going into more details about the project, recent results, and our plans moving forward. So the overall situation. About 3.5 million migrants come here to Thailand for work, and they often bring their children with them. These migrant workers usually come from the neighboring countries of Myanmar, Cambodia, and Laos, and they often find work in low-skilled jobs such as construction or manufacturing. About 300,000 workers and 60,000.
The sound is a bit. We're not hearing you very well. We could hear you very well. Yeah. Can you just check that the mic is plugged in well?
I'm sorry. You can't hear me well?
We can hear Sarah very clearly. Your sound is cracking up, actually. So it might be something to do with your connection.
But I think some of us are hearing you cracking up and others aren't. So I'm not sure what's going on. I'm waiting to IT to see whether there's some issue with the
I'm sorry, Francesco. I actually can't hear you very well. I'm not sure what you're saying.
Please go ahead. Please go ahead.
Okay. I'm going to continue. So as I was saying, about 300,000 workers and 60,000 children are connected to the construction sector in Thailand. And they usually live in construction site camps with slum-like conditions. Now, when I say construction site camps, I'm referring to living accommodation provided to workers and their families by the companies by which they're employed. And these camps are usually very hazardous and unsanitary. Migrants usually migrate to different job sites for work and therefore to different camps. And this constant migration, in addition to a lack of Thai language skills, a lack of documents, and other barriers, affects their access to public services, including health services. Now, companies that employ migrant workers are supposed to register these workers in the Thai social security system, but a lot of companies don't because there's no real incentive for them to do so. And through the social security system, they would have access to healthcare. Separately, children can be registered in what is known as the Migrant Health Insurance Scheme, but many of them are not. Parents often don't have the knowledge of how to do this, or children lack documentation, or constant migration makes registering not worth it. Because through this scheme, children are assigned to a single hospital for an entire year, and if they move, then they won't have access to that hospital going forward. The pandemic has exacerbated these challenges. Families have become even more vulnerable because they live in crowded environments and are more susceptible to disease. And workers are experiencing a significant drop in income due to the economic downturn related to the pandemic. Based on a survey we conducted early this year, about 66% of workers don't have enough money to last 2 days or less if they lose their jobs. And about 64% of workers are in debt. A lot of them are in considerable amounts of debt in the millions of baht. The situation is actually probably worse at the moment because this survey was conducted before Thailand was hit by a more severe third wave of the virus, which is actually still ongoing. Due to this third wave, many families were also unable to leave their camps due to COVID restrictions. For example, in Bangkok, COVID was spreading rapidly amongst these workers, so the government actually enforced a lockdown of these communities for several weeks. Overall, child neglect has increased during the pandemic, which has had a pretty detrimental effect on their health. In terms of health status, about 63% of children had a health issue that could negatively impact their development. 74% of children lacked a health card and were not enrolled into the Migrant Health Insurance Scheme, and 49% were assessed as having poor personal hygiene. One of the children that exhibited the possibility of having a health issue was a boy named Kay. Kay is a boy from Myanmar who lived in a construction site camp here in Chiang Mai. He has no documentation, and so it was unclear to our staff when they met him how old he was, though we currently believe he's about 5 years old. He was born in a rural village in Myanmar, and with the help of a midwife, he was born to a family there. He came to Thailand with his parents shortly after he was born, and he and his older brother T had never been to school and stayed in the camp all day while his parents were at work at the site. His mother told our staff that she believed he had a medical condition that caused him to display concerning behavior, such as not responding when people spoke to him. However, she didn't really know how to access medical services or have the resources to cover the cost of doctor's visits, so she had been unable to get help for her son. In addition, he's not able to even be enrolled in health insurance because he lacks documents. Bandek Foundation works to provide support to Kay and other children living in urban slums and construction site camps in Chiang Mai and Bangkok. We work to support marginalized children in 2 different ways. The first way is through direct support via complementary projects that reach about 2,000 children per year. And the second way is through collaboration with the construction sector to achieve systemic change in the sector. Through this particular project, we work to provide health support to disadvantaged children and families, which has obviously become much more essential during the pandemic. We aim to ensure that these children have sustainable access to care and that their health outcomes improve. And to do this, we combine direct support with construction sector collaboration. This project consists of 5 key activities. The first, outreach and identification. We identify communities in need of support in addition to the communities that we already work with. And this is done through surveys, community referrals, or through existing partnerships with companies and public service organizations. We then identify children and families at risk in these communities, and we conduct needs assessments. Once cases are identified, we move forward with case management. We create a tailored action plan with the child and family, and then work through the action plan with beneficiaries to reach identified goals. We also work with health practitioners to conduct medical assessments in communities to identify health needs, including vaccination needs. Then, based on these action plans and the community health assessments, we move forward with medical support. So we provide tailored support to each case based on needs. And separately, we provide training to construction company representatives on how to facilitate access to health services for workers and their families. The training for company representatives is the key innovation of this project and is part of our Systemic Impact Initiative. The training is based on what we call the Chiang Mai Framework for Action, or the CMFA, which is 12 recommendations to companies for them to support children in camps. You can see these recommendations here. They are focused on the 4 key areas of infrastructure, child protection, education, and of course, health. The CMFA was the result of an extensive research publication on the challenges faced by these populations, which we did in collaboration with UNICEF Thailand. We also then worked with UNICEF Thailand, companies, and communities to develop tools to implement the CMFA, including a community self-assessment tool. Company representatives receive training on the CMFA and its related tools to support them in facilitating access to healthcare. This model aims to provide a sustainable safety net to migrant families, and it's already been piloted with 8 companies in Bangkok, indirectly reaching an estimated 13,000 workers. We hope to set new standards in the industry whereby families would be guaranteed access to healthcare, and this model can also be replicated and expanded to other cities in Thailand where this issue persists. To measure the success of this project, we'll look at several indicators, including the percent of children that reached high vaccination standard, the percent with medical cards, the number of children in camps with improvements around water, sanitation, and hygiene, and access to services, the number that implement a COVID safety protocol, the number flagged for further medical checks, and the number of at-risk children that receive medical support. We have achieved significant progress with this project in 2020. We provided support to over 2,000 children. 86% of children in Chiang Mai and Bangkok were vaccinated according to Thai standards, and required vaccines include vaccines such as hepatitis B, polio, and Japanese encephalitis. And 44 camp management staff were trained from 2 companies in Bangkok. So far this year, we've provided about 1,600 children with direct support. 95% of children have been vaccinated according to Thai standards, and we are also currently monitoring the situation with regards to COVID vaccines. And cumulatively, since we began training company representatives, we have trained 79 camp management staff associated with 8 companies, reaching about 39 camps in the greater Bangkok area. Going back to the case that I introduced at the beginning of this presentation, through this project, we were able to provide him with health support needed to improve his overall well-being. Throughout several months in 2020, we accompanied him to doctor's visits for medical tests, and he received several tests, including tests related to brain activity, motor function, hearing, and vision. And he was eventually diagnosed with cerebral palsy and blindness, and he was supported in obtaining the proper medication and treatment for his conditions. We covered all costs related to doctor's visits and treatment, including costs related to transportation, hospital fees, and medications. And through a complementary project, we actually also supported him in enrolling at the Northern School for the Blind here in Chiang Mai. The school is completely free, and it covers the cost of his medication. Though he's now provided with some support at the school, information about his diagnosis has also made it possible for him to begin gaining independence. He's now happy, he engages with others, and he's able to do daily tasks like brushing his teeth. The project is currently ongoing, and we aim to continue efforts to provide sustainable access to vulnerable children in Chiang Mai and Bangkok. With support, in the coming years, we can directly reach upwards of 600 beneficiaries per year and over 10,000 indirect beneficiaries per year. We also aim to train approximately 80 camp management staff per year in both Chiang Mai and Bangkok. Thank you for your consideration of our project, and I'm now open to any questions.
Many thanks, Sarah. And in fact, you had 3 more minutes to go in case, but thanks for finishing early. Now I'd like to invite anyone from the audience to start thinking about questions and putting them in the chat box. I'd like to invite Abhijit, who's on our jury. Unfortunately, the 2 jurors haven't been able to join. We're still trying to figure out why. But Abhijit, would you have any question or comments on the presentation?
Sure. Thanks, Francesco. Thanks, Sarah. Wonderful presentation. Very clear and kind of gave me quite a clear understanding of what you're trying to achieve. I think the case study of K brought this to life and kind of kind of took this beyond just being some dry presentation of numbers and kind of monitoring and evaluation into a story of a real person. So I think that was smartly done.
Thank you.
I liked the overall scope of the program of focusing on a marginalized and a very clearly vulnerable population. Your indicators to measure success are very, very clear and smart indicators, and I think that do and kind of change in those would be very, very clear indicators of success. Now, I have a couple of questions. Okay, and the other thing is, I think it's quite innovative to involve the construction industry in this and use that as a platform of delivering your intervention. My key question is also around that innovative bit, because there are 2 things. One is, how do you ensure buy-in from these companies? I mean, you now have 8 companies on board, I would assume, from what I've read. How do you ensure buy-in from them if you're going to scale this up and take kind of ensure there is greater penetration and coverage of your program? What is in it for the construction companies? What do they gain? How do you ensure their buy-in? And second related question is, how do you indeed what do the construction companies bring to the table? Because you are doing all of the implementation. I would assume for something to be scalable and sustainable, the construction companies themselves need to bring something to the table. What is it that they bring to the table? So those 2 questions would be great if you could respond to those.
Of course. So I'll address your second question first. I would say that what they bring to the table is that eventually we hope that they will sort of take over a lot of the work that we're actually doing at the moment. So through training them, we hope to have them sort of help facilitate access to healthcare, ensure that communities are vaccinated. Of course, there might be a time in which they would still need to partner with a CSO such as ourselves or another CSO to provide some support, but we are hoping that the companies would be able to do quite a lot of what we're doing at the moment. What they would get out of that is a return on that investment. So we have actually already done quite a lot of work in determining the return on investment for companies, in addition to the social return on investment for the community at large. We actually are planning to have a meeting with companies, essentially a public launch of the tools that we've created, in which we will publicly discuss this return on investment for companies. I'm not sure what the other part of that question was.
So how do you ensure buy-in from these companies?
Right. So we work really closely with these companies. firstly. So they trust what we're doing, they trust our expertise, and they've become a lot more aware of the situation. And with the pandemic, there's actually been quite a lot more sort of public pressure on these companies to ensure that their workers are properly sort of taken care of, in a sense. The virus spread quite rapidly amongst these workers, and it became newsworthy. It was kind of all over the news that these workers were contracting COVID and that they didn't have health support. So there is sort of some public expectation now with regards to this issue. And we're also trying to create sort of healthy competition amongst these companies. The public really wants these companies to be acting in an ethical manner. And because some companies are taking steps to do that, we're hoping that within the sector, there will be sort of internal pressure to do that.
Thanks, Sarah. Just one final follow-up question. So all of that is interesting, and what you say, that there's public pressure to change and all of that. But I think I hope this doesn't sound too cynical, but at the end of the day, for the construction company to take this on and sustain it, there needs to be a good rationale on how they are going to make/save money in the longer term. So you said that you've done some kind of modeling of return on investments. Would you like to speak to that a little bit and then explain to us what that looks like?
So the current social return on investment that has been calculated is about a 7-to-1 return on investment. And so every 1 baht that you give, you get essentially 7 baht in terms of social investment. And by that, I mean, the well-being of those populations in general, and the money that would have to be spent to then, mitigate the issues that are currently existent because they lack access to these services. And it ensures that companies are spending less on workers' well-being in the long run. And in terms of investment return for the companies specifically, if their workers and their workers' children are taken care of, then they are able to retain their workers more long-term, and therefore they have more work that can be done in a more sustainable manner. There's less injuries, there's more productivity.
Okay, thanks, Sarah.
Thank you.
Thank you very much. And we have one of our other jurors, Saeda Makimoto from JICA, Ogata Research Institute, who's actually in the audience. So I'd like to invite either to try to connect by sharing audio and video on the screen, or to in fact type questions in the chat, so we can make sure that Sarah gets them. But is there any question from the audience? I don't see any comment from the audience for now. So I just suggest that we thank you, Sarah, and thank you, Abhijit. I suggest we move on to the next finalist now. And I'd like to invite Dilip Kumar Patubala, who's the CDO and co-founder of Uninhibited, to, of course, switch on the screen and unmute himself.
Hello. Are you able to hear me?
Yes, we can hear you well. Uninhibited is, of course, the other finalist, competing for the MIDP award under this category. And like to invite you to present your project. Again, same drill. 15 minutes of presentation and then up to 15 minutes of discussion and questions.
Sure. Thank you so much for having me. Looks like I'm having a technical issue. It says screen share is not allowed.
Azar, can you please look into that? Let me see if I can. No, I cannot turn your privileges. let's give a second to IT to do that.
Can you click on it anyway? It has that red line across, but click on the screen anyway. It should work.
No, it shows the pop-up that screen share.
Yeah, and we need IT. Azar?
Yes. Hello.
Can you please give screen sharing privileges to Dilip?
No, actually, he has already.
Okay.
Just there is a button of a screen share next to the setting button. You'll see a small monitor.
Yes, but he says he's clicking on it and it's telling him that it's not possible.
Ramona, 1 second. João, can you? We have the presentation anyway. So Dilip, what I propose is that I'll ask João to pull the presentation up, and then you give him a sign whenever you need to.
Super. Sounds great.
Yeah.
Sounds great.
Yeah. Okay. Thank you, Ramona, and thank you, Azar. João, are you able to share the presentation? Let's give them a second.
Just putting up. Just a second.
Seconds. Here we go.
Thank you so much, Joe.
This is the representation, yes?
Yes.
Perfect. So you have 15 minutes.
Thank you so much, Francesco. Hello, everyone. I am Dilip Patubala. I'm the co-founder and CEO of Uninhibited, a not-for-profit based out of Bangalore and India. We specifically are working towards destigmatizing menstrual health and sexual reproductive health in marginalized communities across India. Next slide, please. Now, I would request everyone to take a moment and imagine you're an adolescent girl in rural India. You wake up one morning and find yourself bleeding, having your first period. Immediately, you're told that it is dirty, implying that you're impure when this occurs. Next slide, please. The shame stops you from actually having an open dialogue, seeking support, going to a doctor when you're in trouble, stepping out comfortably to either school, work, or public spaces, or for that matter, even touching your own family and loved ones. You might even miss school 5 days a month, accumulating to 60 days in a year. Next slide, please. The community that you live in does not want to engage in a subject like this because everyone believes the period blood is impure and thus restricting your mobility and access to social gatherings. Next slide, please. The story of yours is not unique. Next slide, please. India has the largest number of 10 to 24-year-old menstruators, the largest number of women with low literacy, and also 200 plus million women and girls in India do not have either awareness or access to healthy menstrual practices even today. And COVID has not helped this at all. With increased number of lockdowns and restrictions around mobility and social gathering, there has been a direct disruption of access to menstrual hygiene products and sexual reproductive health products, healthcare services, and also access to information in safe spaces. Earlier, before COVID, women in the community or girls in the communities that we work with accessed free sanitary napkins from government schools or ASHA workers or government frontline healthcare workers. They would be able to go and confidant between the ASHA workers and Anganwadi workers who are the government frontline healthcare workers about their own menstrual health and sexual reproductive health issues. With the restricted mobility and fear around catching COVID, they've not been able to do this, which also has led to steep increase in sexual reproductive health conditions in the communities that we are working with. But because the government hospitals are flooded with COVID cases, and also there's an increasing amount of fear around catching COVID in hospitals, women and girls are not prioritizing their menstrual health and sexual reproductive health during the pandemic. A recent UNICEF report states that there are about 2 million sexual reproductive health issues with every 3 months of lockdown, which only can make us assume the accumulated number of sexual reproductive health issues over the last 1.5 years. Some of the Steep increase in sexual reproductive health conditions include unintended pregnancies, unhealthy abortions, reproductive tract infections, urinary tract infections, etc. Next slide, please. As soon as the lockdown kicked in March 2020, although we as an organization have been primarily a behavior change focused organization working on the ground, we had to conduct an intensive needs assessment study to understand what are the critical needs of women and girls and other menstruators in the communities that we are working with, and how can we ensure that the pandemic has reduced consequences on the sexual reproductive health and menstrual health. What we identified was 3 specific needs: access to menstrual health and sexual reproductive health knowledge, access to healthcare professionals, and they continue to have access to safe spaces where they're able to have a dialogue around menstrual health and sexual reproductive health. Now, meet Violet Rani, a community champion with Uninhibited. She's been working with us for 7 years now. She comes from the communities that we work with. She was an on-ground menstrual health educator before COVID. Now, she's on a mission to make menstruation non-issue and to help women and girls prioritize menstrual health even during the pandemic with the constraints that COVID has brought in. She begins her journey with a 4-step process. The first step is, next slide please. She builds a network of grassroots organizations and conducts socialization of her helpline through door-to-door survey and outreach, where she goes door-to-door, helps people know that there is a helpline that in existence like this, and also builds a sense of trust between people in the helpline for them to be able to easily access the helpline for their information as well as healthcare needs. Step 2, next slide please. She also facilitates hyperlocal campaigns using local media like wall paintings, radio channels, loudspeakers to create the right kind of noise so that there is an increased sense of comfort around menstrual health, sexual reproductive health, so that they're able to reach out to the platform and actually access the services. Step 3, next slide please. While it also encourages the women and girls to subscribe to our IVR-based menstrual health and sexual reproductive health content on our platform. What happens when a woman or girl subscribes to our content is they get automatic calls every once in a week where they just need to answer the phone and there is a 2-minute or 2 to 3 minute audio playing with key messages around how to prioritize menstrual health and sexual reproductive health, even with the constraints that COVID has brought in or otherwise. These come in the form of jingles, conversations between mother, daughter, husband, wife, etc. Once they listen to their audios or these audios, while it also encourages them to, next slide please, to call into a 12/7 helpline where they're able to seek the resolutions, where they can either talk to our helpline assistants or even seek our tele-gynecology services with 0-minute wait time. Next slide please. While its holistic efforts gets paid off when she's able to reduce the impact of COVID and the stigma around menstruation in these women and girls accessing healthcare services and critical education around menstrual health and sexual reproductive health. Next slide, please. Let me tell you how this works in terms of a call flow now. Any woman or girl from across the country can give a missed call to our helpline and they'll get a call back within 5 seconds. Then they get to choose the gender, language, and then they land on our final platform. The platform offers them 2 options, 1 and 2, where they press 1 and they get to talk to our helpline assistants, whom we call Saathis. And these helpline assistants provide them resolutions which are of any knowledge-based queries, like for example, how to use a sanitary pad, how to use a menstrual cup, how many days are there in a period cycle, is white discharge normal, etc. But if the helpline assistant realizes that this is not a knowledge query, but actually a health condition involved, then a conference call happens between the gynecologist, the helpline assistant, and also the person who's calling in. If it's a basic query or a preliminary query, we provide them a consultation and a prescription for them to resolve and do a 7-day follow-up to ensure it's closed. But if it's actually, if the doctor senses that there is actually a critical condition involved, then we do follow-ups and prompt them to actually go to the local primary healthcare center to actually seek healthcare resolution for their health condition. If on the platform they press 2, they get to subscribe to our IVR-based education, where we have bucketed different forms of content like understanding menstruation, how to seek hygiene, how to have conversations around menstruation, etc. But they can subscribe to each of these buckets which interest them, which specifically addresses their own needs, where they get automatic calls week on week, to actually educate themselves. After any of these engagement across the platform, they get to do a post-test for us to understand the effectiveness of the engagement immediately. Next slide, please. We have made critical information and healthcare accessible to nearly 120,000 plus women and girls and other menstruators since June 2020. And we are on a mission to reach 250,000 plus engagements this year. The helpline is currently available in like 4 languages, which includes Kannada, Tamil, Marathi, and Hindi. We are intensively targeting our outreach in 4 districts in 4 states in India, that is Bihar, Madhya Pradesh, Maharashtra, and Karnataka. These districts have been selected because of the lowest indicators of gender and sexual reproductive health and menstrual health. Next slide, please. Our recent impact study states that 80% of the people who have engaged with our helpline have been able to access doctors easier and faster because of the pandemic. 90% have understood their issues clearly so that they're able to prioritize them. 78% have felt heard and respected by the helpline assistant. Let's remember, this is a subject that they don't talk about within their own households. So they're actually being able to call and helpline and actually feel respected and acknowledged is a huge progress in how motivated they would be in seeking sexual reproductive health going forward. Out of 66% of the people who have engaged with us through either a doctor agent or a resolution, 44% have started their new menstrual health practices, which means that the behaviors are actually shifted from where they were earlier to where they are now. Which is also an incredible insight for us because we have been trying to shift these behaviors through an intensive on-ground program. This is also validation that a part of that can happen through a virtual platform like Hello Saathi. Next slide, please. These are some of the data dashboards for us to understand, like how are people getting to know about the helpline, like while it like community champions are playing critical role, like almost 96% of our engagements are coming through community champions, which is an incredible insights. The top queries people are calling in with are either period pain, white discharge issues, irregular periods, discomfort, etc. Majority of the calls from across the India are now concentrated in Madhya Pradesh, while we also see an increased uptake in calls from other states like Bihar, Maharashtra and Karnataka, because we have increased our intensive outreach in these regions lately. Also, if you see a typical day, what we're intentionally focusing on is ensuring that we're able to build the capacity of the helpline assistants so that they're able to resolve the queries by themselves as much as possible. And also our intention is looking at the patterns of queries that are coming into the platform so that we can use AI-based technology so that we're able to reduce the number of consultations that are going to the doctor, but we're able to handle the preliminary concerns either through the technology or the helpline assistants themselves. Next slide, please. This provides us further data on the gender, like 94% of the people who are calling in are women. And also we ensure that each person who's calling into the platform has a separate record within the system so that we're able to build on that record as and when they call again and again, instead of having to start the case from a starting point again and again. Next slide, please. The current per beneficiary cost of the helpline is about $2, which is about 150 rupees per person. And we see that reducing to $1.64, about 120 rupees, by the end of this year as we scale to 250,000 plus engagements this year. Next slide, please. The cost is split between outreach, technology, grassroots workers, head office, and monitoring evaluation. Interestingly, outreach takes up a significant chunk because we realized building the trust with the platform is a huge factor for us to increase the engagement. Next slide, please. We're talking about innovation. We look at innovation of this platform in 5 different angles. In Hello Saathi is the only menstrual health and sexual reproductive health platform which is providing access to information and specifically focusing on menstrual health right now. In terms of cost, it's a free platform for the people who are calling in, and it's very cost effective for us. Like our on-ground engagement before COVID was 450 rupees per person, and we have been able to reduce that to 150, 120. Although we're achieving reduced outcomes, we see a significant role that the platform is playing in achieving the outcomes that we were targeting. Ease of access, people just need to give a missed call. They don't need a smartphone. Through a basic dumb phone, they're able to engage. And the platform is available in 4 languages, and replicating it into more languages is not a difficult component at all. People who are calling in have privacy, anonymity, safe space, because this is a subject that has high stigma. These factors play a huge role in how well they're able to engage with the platform in itself. It's easily replicable from region to region. It's plug and play because the platform is standardized. We can either plug in into a government program or a network of organizations, and also expand our programs to other stakeholders, which I'll get into later in the conversation. Also, what we realized is with 120,000 plus engagements, we've been able to build rich data around menstrual health, which was lacking so far in the ecosystem, and which we're now thinking about how to put that data to effective use for it to have a positive influence in the ecosystem in itself. Next slide, please. Scale, we are planning to scale in like 3 different angles. One is using this to sustain our behavioral change program, which we were doing before COVID and which we will soon start after COVID. We are expanding the work to new stakeholders like sex workers and LGBTQIA+ community, who are the most vulnerable groups anyway, COVID or no COVID, with respect to sexual reproductive health. And through partnership with district administration and a network of organizations, we're reaching out to 250,000 plus people this year. Next slide, please. Some testimonials on how people feel comfortable talking to our helpline assistants, how they see a benefit of having helpline assistants who come from the same background, because they're able to share their experiences very well, and how people are moved from a place of shame to being uninhibited and seeking sexual reproductive health on our platform. Next slide, please. We're on a mission to reach 2.5 million menstruators in the next 4 years. Join us in this journey to destigmatize menstrual health and sexual reproductive health. There are a couple of slides on our team on donors, which I can take you through if you have any questions. Thank you so much. Open to Q&A.
Thank you very much to you, Dilip, for this very clear presentation. But before, I'd like now to invite our jury members to ask questions and comments, and of course, welcome to Dr. Saeda Makimoto who was the second juror who had some trouble connecting earlier. Welcome and thanks for joining us. We'll make sure that you have time to ask questions to Sarah at the end of the session. Anyway, we're running a little bit earlier, so we should have time. And now let's focus on Dilip's project. Who would like to start? Abhijit, Makimoto-san? There you are. Okay. Abhijit, would you like to start?
Yeah, just a couple of questions. So, Dilip, wonderful presentation, and I
Abhijit, I'm not able to hear you.
Oh, can you hear me, Francesco?
I can hear Abhijit very well. But
Yeah.
Dilip, can you?
I can't hear him actually. Like I had trouble earlier as well.
Okay, can you hear me now?
Abhijit, you can go on. I have a colleague listening to us. She'll drop notes in the chat box with questions you have. Yeah.
Okay, sounds good. So thanks, Dilip. Wonderful presentation. We took us through the whole the different things that you're going to do, and just like Sarah, you also kind of made it come alive by using real people's stories to elaborate or illustrate your program. I have 3 questions, and I'll if I assume your colleague is going to note them down, and then you can answer in whatever sequence you want to. So the first one is based on your experience of having now run this program for quite a while. Moving forwards to a kind of a major scale up now, if you were to get this award or otherwise, I would assume, what are the kind of implementation challenges that you anticipate, and what are the mitigation strategies for those implementation challenges? That's question number 1. Question number 2 is, I think there are definite advantages to using technology, as we all know. We can scale up faster, we can increase the coverage, and you're not limited by geography, you're not limited by the number of people you have, etc. But there are also disadvantages to it in a place like India. So for example, who has access to a phone? The inequity that comes from the imbalance in access to phones. So for example, you're looking at marginalized populations, and maybe there is only one phone, and this is from experience. Maybe there might be one phone in the family, and that phone is held by the man in the family. and that the person who's going to ask these questions, or the person for whom this program is, might not really have access or limited access to it. And also then there are questions about privacy if you're using a shared phone within the family. So what are your thoughts on that? That's the second question. And the third question is coming from a concern. It's great to hear your ambition. I love your ambition. You kind of saying 2.5 million people by 2025. Great. I hope that you'll achieve it. But that also concerns me because sometimes in the rush to scale up wide and very fast, we end up making mistakes. So, what are your thoughts on that? I mean, how would you assuage my concern about the scale of your ambition? So, although I congratulate you on your ambition, and I'm great that you want to achieve all of that, but I'm still concerned. So, how would you kind of make me feel less concerned?
Thank you. I'll wait for my colleague to actually pen it down for the last part of the conversation. But I wish I could hear you directly. But yeah.
Yeah, apologies for the because I can hear both very well.
Yeah.
Our IT team is looking into it, but we haven't had any major issue during the conference. So I think we're about that.
Thank you, Pradna, for doing this. This is very helpful. Thank you for the kind words, Abhijit. To your first question, based on your experience moving forward, major scale up, what are the kind of implementation challenges and mitigation strategy you have? There are 2 to 3 specific challenges that we are experiencing, or we are anticipating that we will experience as we move forward. One is providing free gynecology services is a limitation, because now how many doctors can we provide on the call is a big question that we are carrying. So the 2 ways that we are navigating this. One, earlier we had doctors available through the day, which we realized was not sustainable, because people were not calling through the day, and there were specific hours that we realized that people are actually calling in for consultations. So now we are asking for gynecologists only for those 1 hour, 2 hour slots in the day, so that we're able to do the maximum number of consultations during that particular hour. So as we work, data is really helping us understand where do we need resource and how exactly can we put that to use. And the second is, like I mentioned during the presentation also, is how can we use AI to reduce the number of doctor consultations, where if you're seeing like people have white discharge issues is one of the standard big reasons people are calling in with. So are there any preliminary recommendations that we can make to people if they have white discharge issues? What kind of white discharge issue needs to go to a doctor? What kind of white discharge issue can be resolved directly by suggestions through using AI recommendations is something that we are doing. And second and third, we also have launched a doctor volunteer program, which has turned out to be pretty successful so far, with doctors volunteering and saying, hey, I'll volunteer for 1 hour, etc. But sustainably long term, the way we're looking at this is, if we're able to like really convince the district administration, we want the doctors from the public healthcare systems to play a better role here. And we don't want people in the communities to look at this as the sustainable solution, but we want to use this platform for people to actually proactively seek the local primary healthcare centers as a sustainable solution. So how can we build stronger relationship with doctors in these districts better, so that we're able to like recommend people to them, and people are able to like reach out to these doctors in a much more comfortable manner, which seems like the biggest challenge right now. It's something that we are working towards. The second is also, if we really want to scale this up with the governments in the districts and other districts that we're working with, the NFHS indicators become a very critical role, like how many people are getting the breast cancer tested, cervical cancer tested, etc. So those, how are we really able to influence those indicators through our platform is something that we are really working towards, because that seems like the easy segue for us to like partner with the government agencies, because that's how their reporting structures are really inbuilt on. Because now RTIs or UTIs or like these indicator or menstrual hygiene practices are not the factors that they're really looking at this point of time. So how can we really align the effectiveness of the platform with the government indicators is something that we really are looking at. Please feel free to share your follow-up questions. Pragna might drop in a note as well. In terms of a second question, with limitations of technology, absolutely, and we don't see this platform as for everyone in the country, and we do acknowledge that there are inequities. Number of women who are mobile phones in the regions that we're working with is still significantly low. Majority of the families have one phone, like what you have mentioned. But what we have also realized is there are patterns of the hours where women in the families are engaging with us on these platforms. Like when we're saying 120,000 plus engagements have happened, these have happened in tribal villages of Jhabua, Jamui, Palghar, etc., where this is a lot of data for us to like think about what is working, when are people engaging, how exactly do we want to engage in these specific hours, because what we realized is either women are engaging early hours or in the late evenings. So because the mobile phone is with the man during the day when they go to work, so that is playing a huge role. And second is how are we engaging with men to be able to like they being able to offer their phones to the women and their families to be able to engage. This is also the second part. So we have a separate pilot going on how to engage with men and boys so that they're able to provide supportive systems within their families. But we also realize that there is significant population within these districts who have mobile phones, at least one mobile phone within their households. So that is our target groups right now. And I wouldn't say that this is a platform for everyone in the country to seek sexual reproductive health or menstrual health. Third, love the ambition of 2.5 million people. Concerning the rush of scale up wide, we might end up making mistakes. How can you ensure and make feel less concerned about this vast ambition to scale so quickly? Absolutely. And this is something that we have been very cognizant of, because in 2018 we got too excited and we did scale to 10 states and we did burn ourselves in the process. So since then we have been very cognizant of how are we not making the same mistakes, how are we not losing the quality of work, how are we not ensuring that there's too much churn within the team in terms of the amount of work that we're expecting out of them. So we are putting a lot of thought as we get into the post-COVID world on how do we want to roll out our behavioral change programs and the helplines to ensure that this is thought through and capsuled, modularized, and not really putting strain on a few members of the team to hold on to the fort too tightly, and how are we looking at quality of work as a non-negotiable as we scale. A couple of things that we are doing also is we are not scaling to too many regions, but we're scaling in the same regions into a deeper capacity. So when we've chosen these 5 districts, we want to scale a program in the same 5 districts over the next 5 years. So the variabilities are reducing because we're working in the same group, same partners, and we know the people very well, and there's enough data for us to understand what is the kind of problem and what works well. So what are the few things that are staying common while we scale across these 2.5 million people is something that we are really consciously thinking about, and how can we use technology to train people and ensure that the quality of work is not compromised is the second thing. And the third thing, which I have not mentioned through the presentation, is we scale a work through a program called the Period Fellowship Program, which is a 15-month paid full-time fellowship program. So this really enables us bring in a lot of energy and consistency through the program, because there are these new hyper energetic folks that are coming into the program, and they're so excited that they really want to like achieve the world during the 15 months of the fellowship program. And that energy really helps us stay true to the momentum of work. And also because they're really here to learn, they go through the cycle of making mistakes, learning, and making sure that we're able to realign to our quality of work as well. So that really has helped us scale the program over the last 3 years, and this 120,000 engagements in a similar manner.
Thank you, Dilip. There's a question from, there are 2 questions from another juror, Saeda Makimoto, in the chat. So one you addressed in part, it's about how do you make sure that technology actually compensate, the inequity built, that is linked to technology itself, is taken care of, when you're actually trying to reach the disadvantaged group already. And the second one is who pays for doctor's consultation now, and what's the plan? So how does access to finance affect your plans?
Absolutely. I think access to finance...
Sorry, but we have 4 minutes, 3-4 minutes left. And I would like to shift to the next.
Yeah. So I see the question from 2 lenses, access to finance and access to doctors sustainably. So access to finance is something which we are not too concerned about, because we are not paying the doctors either. So the doctors we have are volunteer doctors right now. So we're not paying doctors to, which could increase the burden of we having to raise more money. So volunteer-based programs are working really well, and we see a really high uptake of the number of doctors who are volunteering with us for a fixed term. Like they volunteers with us saying that I want to volunteer 6 hours per week for the next 6 months. So they have a rota in place, they have a schedule in place, they know which hour in the day they're expected to show up, and we're reducing the number of minutes they're taking for each consultation. Earlier, the number of minutes per consultation was about 15 minutes. Now it is reduced to about 7 minutes. So our efficiency within the system was also helping us address a larger number of consultations within a given period of time. But sustainably, as we look at it, we do acknowledge that this is probably not a sustainable way for us to depend on a volunteer-based doctor program. So that's where I think the public healthcare systems play a better role or a larger role in terms of what roles can doctors from public healthcare centers play in the system. There is eSanjeevani that is launched, which is a teleconsultation government platform right now, where people can seek video consultations through video calls, and that has turned out to be a humongous success in certain regions across India, if not all. So there are resources that are in place by the government bodies which we can put to use if we are able to really tap into them and convince them. So how can we really associate, collaborate, partner with government agencies to be able to provide sustainable doctor support is a question that we are currently pondering over, and hopefully we'll arrive at a solution soon.
Thank you very much, Dilip. So I think I don't see any other question from the audience. So I think we can move to the next project. Thanks a lot, Dilip.
Thank you so much, Francesco. Thank you, Abhijit. Thank you, Saeda.
The third project, the third finalist, is an NGO called United Way of Mumbai, and Dr. Shailesh Wagle will be presenting on behalf of the organization. Shailesh manages the health-related projects at United Way Mumbai, and the project is called Establishing Infection Prevention and Control Mechanisms in Public Hospitals, and imagine this is in India. Shailesh, welcome, and same drill, 15 minutes of presentation, 15 minutes of comments. The floor is yours.
Thank you, Francisco. I hope I am audible, visible, and the presentation is also visible to all of you. My name is Dr. Shailesh.
Oh, good.
Thank you. My name is Dr. Shailesh Wagle. I am a medical doctor and a public health professional working with United Way Mumbai. We are part of the Global United Way network, and we are based out in Mumbai. And what I'm going to talk to you about is the infection prevention and control in public hospitals. I think most of us know that COVID-19, India is the second worst affected country, and Mumbai suffered a lot during COVID-19. And it opened up a Pandora's box of challenges which we never identified before. In this picture, you see me training the class 4 staff, the cleaning staff, the ward assistants, the cleaning ladies of the hospital about how to wear a mask, how to dispose of a mask. Me and my team at United Way Mumbai during the pandemic, right from March, when the lockdown happened in the nation, provided thousands of masks and PPE kits to government and public hospitals. But what we understood is that they were unaware how to use that, how to dispose that, how to ensure that the infection does not spread inside the hospital. And that is what I'm going to talk to you about. What is the challenge that we faced? What are the reasons? What are the interventions that we propose? What is the impact and the growth that we have seen? The strategy of our project, few glimpses of what we have been doing so far, some testimonials from our healthcare workers, prospective outcomes, and how this project can be a sustainable and expandable one. So, as we all know, more than 34 million cases and 400,000 plus deaths India has witnessed, and Maharashtra, where Mumbai is located, is the worst affected state. But when we look at this as a challenge, we have other challenges which are below the tip of the iceberg. India's doctor-to-patient ratio is close to 1 to 1,500. And if we compare this with the other worst affected countries like US, where it is 1 to 300, or Brazil, where it is 1 to 500, India struggled a lot to identify doctors, to identify the public health system which can cater to the burden of patients that were coming in. And that resulted in more than 87,000 plus of our healthcare workers who got infected because of COVID-19, and more than 1,000 of them lost their life. And that's why COVID emerged in the later phases as a hospital-acquired infection, an infection that spreads inside the hospital to the healthcare workers, to the patients who are not admitted or not taking treatment for COVID, but are still getting affected because of COVID. And this is not only the story of India. There are many countries where this sort of scenario is already happening, and we have lost, like you see in the news articles, many doctors, many healthcare workers because of COVID. Now, why this happened? So first thing first, India's public health system and the infrastructure that we have felt inadequate. It fell short of catering to the number of patients that were coming in, and then there was lack of preparedness. We never faced a pandemic. We never faced number of cases started, and our healthcare workers, the nurses, the ward boys, the cleaning staff were never used to do this, especially when we talk about cases of an infectious disease. And also because they lacked a frequent training. When we look at infectious diseases and the trainings that happen, it is generally the doctors, the medical officers who get regular trained, even though not as frequent as it is required. But when we talk about the staff, take for example a security guard of the hospital, he is never aware of what to do when such situation happens, how to keep distance, how to protect himself. And then there are issues with the compliance of infection prevention and control. All the top three lead to the compliance issues. There are shortcuts being taken. People do not follow the infection prevention control protocols, which are given up by the Ministry of Health and Family Welfare. And then the situation turns into a major source of infection inside a hospital. So when we talk about interventions, what can be done to stop this spread of infection inside a hospital? It's inside the establishment which is supposed to treat patients, which is supposed to take care of patients, is to strengthen the IPC protocols. Right now, if we look at any hospital in the country, the focus is on treating patients, but not protecting the doctors and the rest of the staff. We need to strengthen that. We need to have equal focus of the system on protecting their staff. We need to facilitate implementation. We understand that the public health system in India is not hugely funded. It is falling short of human resource. It is falling short of good quality equipment. We can facilitate that. Trainings, regular CMEs can help people understand this more, practice properly. And that's why we also need to build capacity of our healthcare workers. When we talk about the healthcare workers such as cleaning staff who are not regularly trained and who also do not really understand the jargons of the IPC protocols that have been set up, building capacity through trainings, through giving them documents, giving them material that they can refer to in their language, which is easy to understand, can definitely help them, and then document the proof for impact to scale. Such interventions have not happened. We are putting the focus on strengthening the IPC, and the situation mandates it right now. Government is also focused on how it can be done. So we can clearly make a good documented proof that shows what works to strengthen the overall IPC. What we have done so far, how did we start? This whole concept started when we started visiting hospitals with PPE kits, with masks. We figured out that many of these hospitals, even though they are short of equipments, they are really short of knowledge. They are really short of trainings. So we started with one hospital, the first one that you see in the opening page where I'm training the hospital staff. We started with that one hospital because yes, we felt a lot of resistance from these hospitals who felt that we are doing an audit, who felt that we are doing something that they are supposed to do and we are trying to point fingers. So we convinced one hospital and started as a pilot in October 2020. And I'm happy to say that by now, we have got multiple requests. We have got multiple donors such as UNICEF, who have supported us in these interventions, and we have scaled it up to 28 public hospitals in Mumbai itself. When we started again, we had 150 staff who registered for the training. Not everyone attended it because we had to take care of their shifts and all. But right now we have 838 staff who attends regular trainings from our team. And then there is this concept of Hospital Infection Control Committee. This is the committee of the core staff, the senior staff, including the medical officers, the matron, the chief of the institution, such as the Municipal Corporation of Greater Mumbai or the state government, who are supposed to devise strategies, who are supposed to audit and monitor the in-house infections inside the hospital. And what we figured that in most of the hospitals that we visited, these were on paper. These were not really active. They were not really doing their task. So when we started with establishing 2 hospital infection committees. And now we are proud to say that all the 28 hospitals that we have full-fledged working hospital infection control committees who do their regular meetings, their audits, and their monitoring and reporting. What is our strategy? So first, when we reach the hospital, we strengthen the Hospital Infection Control Committee. We develop an in-house IPC protocol. These are protocols which are customized to the hospital, which are in their local language, which do not have the jargons, and which are also customized as per the designation. For example, if we have a doctor, he has a separate module, and if we have a cleaning staff, he has a separate module. We do a detailed need assessment of the hospital's infrastructure, including the civil work and the equipment, and we do infrastructural changes. We do cleaning, we provide them cleaning material, new autoclaves, new decontamination equipment, fresh linens, fresh curtains, and whatever it is that they require to ensure that their hospital is protected from any in-house source of infection. We set up IEC material, information, education, and communication material like posters, signages for easy guidance to hospital staff and also the patients and the relatives who are coming inside the hospital to understand what are the do's and don'ts to prevent any sort of cross-contamination. We have periodic training of nursing staff on topics like hand washing, biomedical waste management, surgical site infections, and many more that is required by them, and it is done in consultation with the medical officers. We do CME sessions for the doctors, the medical officers, because they are also not really updated on many topics. One of them was mucormycosis, that figure that we just came to know after the COVID, and we conducted CMEs for doctors like that. And then there are preventive medical initiatives for the hospital staff, like vaccination for diseases like hepatitis B, which is a bloodborne disease, a very common disease that can go from a patient to a nurse via needle prick. Just to give you a few glimpses.
Actually, 5 minutes.
Great, thanks, Francisco. Project glimpses. This is my team. You see in the blue T-shirt. This is a team of public health experts who train the nurses, who train the doctors, who do the need assessment, and who undertake the entire project. And we find happy faces. We have got good remarks, good feedback from the nurses who say that the training that we do are basic, simple, and very clear for them to understand. And then it is not something that they have done before. It is not something that they have attended on a periodic basis. So that is why they are really interested in attending those sessions. I would like to say that when we started, the attendance in one hospital used to be somewhere between 4 to 10, and now we have it somewhere between 20 to 50. So that is a change that we really see. What do we want to do? We want to go step by step. We are looking at any hospital that we can engage in the project, any grant that can help us in adding 1, 2, 3, 10, 200, 300 hospitals. We will go for that. We will, with this grant, we want to select one hospital, which is a public or a government hospital in Mumbai. We want to strengthen their HICC. We want to do 6 trainings for these hospital staff or more as required. We want to do CME sessions for the doctors, which are every 4 months. We will do infrastructural changes. We will do a detailed need assessment, figure out what is required, figure out equipment or the civil changes that are required and do those. We will do medical interventions for the hospital staff like vaccinations and a comprehensive impact assessment that can go further to the state, to the country, which can be scaled up by us and by the government together. How the project is sustainable. The project is a collaborative effort between United Way Mumbai and the local administration. We have hospitals from the municipal corporation, the state government, and the staff. The overall administration is done by them. United Way Mumbai is a facilitator in these trainings. We are the facilitator in bringing change. But at the end of the day, the ownership of the project relies with the Hospital Infection Control Committee and the administration itself. We have had good talks with the municipal corporation, because of which we could expand this project to these 28 hospitals. We are focusing on cost-effective interventions that the government and the administration can do later on, which are trainings, which are giving good signages, good IEC material, a simple training module. And there is always a need to revisit the public health in India. This can be scaled up to any hospital, which is a public or a government hospital in the country, because the situation is almost uniform. The modules stay the same. For nurses, the cleaning staff, the doctors, modules stay the same. It's only the language that needs to change. It's only the way it is implemented that needs to change. So it's a very scalable model, which can go across the country and which we can extrapolate to the entire nation. So this is where we are. And as United Way Mumbai, our aim is to make this change, not just in these 28, but say 2,800 or 28,000, as much as we can, and help our healthcare workers to protect themselves, to protect their families, and protect the patients who come to them to seek help. Thank you so much.
Thank you very much, Shailesh, for the presentation. I'd like to invite, of course, the jurors, Abhijit, Nadkarni, and Saeda Makimoto to start asking questions. Makimoto, if you are unable to connect your mic still, please just add them to the chat, and we'll make sure we address them. Abhijit, would you like to go first?
Sure. Thanks, Francesco. Thanks, Shailesh. I mean, thanks for an informative presentation, and it's good to see something happening within hospitals.
Francesco, is it me or getting some disturbance? Sorry.
You also can hear Abhijit. I can hear Abhijit very well.
Sorry. I think I lost my network.
Okay, can you hear me now?
Yes, I can.
Okay, so I was saying, Shailesh, thank you for that presentation. Very informative. Good to see the work that you're doing, and good to see that it's different from the other two presentations. Those were community-based interventions. Yours is a hospital-based intervention, and particularly relevant for the current circumstances that we find ourselves in. I have two questions. One is, what is innovative in your project? I mean, I failed to grab that, because it does seem to me that your program is built on doing a lot of education, yes, and also kind of providing materials that people can use to meet the aims that you're trying to achieve. And as we know from evidence from a lot of different domains and fields, that doing training by itself is not very useful in changing behaviors. It changes knowledge. At best, it can change attitudes. But changing behaviors is a lot more complex than just doing CMEs and educational programs. So what is your response to that? And the second question is around the success criteria. It's not clear to me how you are going to evaluate the success of your program. What are the kind of indicators that you are planning to look at, or have indeed looked at in the places that you have implemented this program, for you to decide, okay, this is worth scaling up because this has led to these changes on these various parameters over this period of time?
Right. Thanks, Abhi. So first of all, when we talk about the project being innovative, this is something that is a long-term intervention. So we are not really looking at doing something in a very short time, like a year or two, a month or two. We are looking at long-term programs. We are looking at long-term engagements where my team is there in the hospitals every week to talk to these doctors, monitor the nurses, how they have been doing this. And this is something that, when we looked at the COVID response that started, there was a lot of support in terms of equipment, in terms of ventilators that came to the system. But when we look at the situation where the nurses and the hospital staff is, only providing them with equipment is not going to suffice. Like, from my experience, I'll tell you, simplest of an example, when we gave PPE kits to these hospitals, we could see used PPE kits thrown near the basin of a doctor's room. Now, that is not going to help. Giving just a PPE kit, but somebody not understanding how to use it, how to discard it, or how to take care of it is not going to help. It's going to make the situation even worse. What we are trying to do is ensure that they are aware of what it needs to be done with these. And it is not only for this pandemic. We are looking at a potential third wave coming to the country. We are looking at potential high number of cases coming in children because adult vaccination is happening. And any sort of such infectious diseases, take for example HIV, hepatitis B. There are hospital-acquired infection cases that we see on day-to-day basis. And even if one life lost because of hospital-acquired infection in a nurse, that's a major loss that we should count, because we already have very less number of healthcare workers for our patients. And if we happen to lose them because of an infection that can easily be controlled inside a hospital with simple interventions like training them or ensuring that they follow the protocols, I think that will make a lot of difference. And end of the day, we will have a better healthcare system. Being from public health background, I know that public health systems are based on people and not on equipment and infrastructure only. You need people to act in a certain way. You need people to follow protocols in a certain way. And I think, that is why many of the countries could contain the infection, but we are still struggling to do it. So if we can save these people, and this is something that is not happening. We get requests from the corporations, the administration, that you guys do it, because they don't have the bandwidth right now to conduct these sort of sessions, to conduct these sort of interventions. India's overall budget for health of the total GDP is somewhere close to 1%. They don't have the resources right now, and this is urgently needed. So that is why we have jumped into this. And sorry, I lost your second question in the whole phase.
My second question was around your success indicators. How do you determine what you're doing is working, or if you have not done that, then in your scale-up plans, what are the kind of monitoring and evaluation plans you have?
Yes. So every hospital has data on hospital-acquired infection. Every hospital keeps a note of that. And what we see right now, it is around 2 to 3% annually that the hospitals report the hospital-acquired infection. Our goal is to reduce that, to reduce it to less than 1%, ideally. Second is the Hospital Infection Control Committee. That's the core of the entire program. If we right now see any hospital, which is a public hospital, the committee is on paper. They don't have monthly minutes, they don't have audit reports, and they don't have most of the documents that they're required to monitor. Our goal is to ensure that they have this periodic monitoring going, they have their meetings going, they have the audits going. And if we can do that, this is where we exit from the project. This is where the project becomes successful. It becomes easy to hand over to the administration, where they take care of the entire program. These are the 2 points that we are focusing on.
Thank you.
And Shailesh, there are two questions as well in the chat for you.
Yes. Yeah, I see this.
Targeting of your project.
Yes.
You know, 28 versus 3, and then of course testing capacity in hospitals. Well, you have the information about that. Can you please address those in like 3-4 minutes?
Sure. I see Saeda's questions. Firstly, yes, 28 hospitals. This is recent development. You know, after the proposal was done, like I mentioned, UNICEF was one of the partners who came on board after looking at the project that we are doing right now, which was going around with 4 hospitals. And with UNICEF support, we could add 25 new hospitals to this project. And this is where the project has scaled up, recently. So I think that's a question that, and one hospital, yes. Because with the support that, or with the grant that we have, we can cater to one hospital for a long term, rather than doing multiple hospitals for a short term, which really does not make that much of an impact. So we're looking at one hospital and doing the entire 1-year period where, we do hardcore interventions with them and we do a lot of monitoring. Yes, Japan's experience, public hospitals, yes. When we look at testing capacity for early detection, it's little tough right now. Most of the doctors and few of the nurses are tested for diseases like hepatitis B and all. But when we look at the ancillary staff, when we look at cleaning staff, the ward assistants, the security, admin staff, they really don't have undergone these sort of screening or testing. And this is where the idea of doing a complete testing, complete vaccination of the hospital staff is necessary, because we don't have that sort of resources being invested by the government for the entirety of the hospital. So I suppose that's the question that Saeda was asking.
Thank you, Shailesh. I don't see any other question on the chat, so I think we can close the public session here. Thanks again, Shailesh, for your presentation.
Thank you. Thank you so much, and best of luck to everyone. Thank you.
This is the end of the public session. Now, what will follow now is that the jury will actually meet in a separate virtual room. And just a quick note to the jury members: you just received the link to that room in your email inbox. So again, once more, thanks a lot. I'd like to invite everyone, of course, to the award ceremony, and that will happen on Tuesday afternoon European time. Please check the program. It's we will have, of course, a celebration of the 20 years of this competition, testimonies from past winners, and we'll end with the announcement of the winners. The jury now will decide how many prizes to give. All 3 projects might be awarded or less, and we'll also decide who will get whether to give 1 or 2 first prizes. Or not, and whether to give a third prize, of course. So I look forward to seeing all of you on Tuesday afternoon. Again, European time. Check the schedule for the time in your time zone for the announcement of the winners. Thanks again, Sarah. Thanks again, Dilip. Thanks again, Shailesh, and our jury members.
Thank you.
Thank you very much.
Thank you. Thank you, everyone. Thanks a lot.
Bye-bye.
Bye.
Makimoto-san, we are going to switch to Zoom so that perhaps we can, everybody has all experience with Zoom. Perfect. So in 5 minutes, we'll just switch to that. Thank you.